You can be the strongest nurse on the unit, the one who never cries at work, who always shows up, who always says, "I'm fine." But here's the truth. We are not meant to carry this much stress, this much grief, this much pressure alone. Whether it's burnout, compassion fatigue, anxiety, or just feeling numb after a string of back-to-back shifts, mental health support is essential, and Rula makes it possible. That's RULA. Rula is a mental health care platform that connects you with licensed therapists, real professionals in network with your insurance, and they help you get started fast. They accept most major insurance plans, and sessions can be as little as $15. Depending on your benefits, you might even pay nothing. Rula doesn't just match you with a therapist, they stick with you. They make sure you're making progress and that you're getting care from someone who truly fits your needs. Thousands have already trusted Rula to support them on their journey toward improved mental health and overall well-being. Head on over to rula.com/nursemo to get started today. After you sign up, they ask you where you heard about them. Please support the show and tell them that this show sent you. Go to rula.com/nursemo and take the first step towards better mental health today. You deserve quality care from someone who cares. Let's be honest, your shift starts before you even step foot on the unit, and what you wear can really set the tone for the entire day, and that is why I love FIGS. Back in nursing school, I wore those standard boxy scrubs that felt like a scratchy paper bag, but not anymore. FIGS are so much better. They're flattering, they're super comfortable, and they're designed for people who actually work in healthcare. Plus, they're antimicrobial to help keep you protected. They're durable enough for endless washes and stylish enough that you actually want to wear them. If you're new to FIGS, I recommend starting with the Catarina top and the Cade pants. The Catarina has a relaxed, easy fit that's perfect for moving through a shift, and the Cade's cargo pockets keep all your go-to supplies within reach. You can get 15% off your first order at wearfigs.com with the code FIGSRX at checkout. That's wearfigs.com, code FIGSRX for 15% off. Hey there, it's Nurse Mo. Now, before we dive into this Encore episode that takes you through a mock code blue, I want to share something that I'm really excited about, and that is Confident Nurse Academy 2.0. Now, you may remember that I launched Confident Nurse Academy a while back with my nurse bestie, and we have got a new updated version launching November 8th. So this updated version of the Academy is now approved for CE credit and has been completely redesigned with evidence-based tools, downloadable cheat sheets, and a brand new shift strategy workshop, which is a step-by-step system that helps you plan, pace, and personalize your shift like a total pro. Plus, we now have 3 tiers to the Academy. We have the solo tier for the nurse who wants the roadmap of the Academy at their fingertips and the freedom to do things on their own. And then we have Squad, which is the mid-level for the nurse who doesn't want to go at it alone. With the Squad option, you'll get the full Confident Nurse Academy program plus live coaching and guided support all year long. And then the third tier is called Boot Camp for the nurse who wants to fast track their confidence and walk away feeling ready to run their shift like a pro and no second guessing. That's what you get with Boot Camp. This Boot Camp tier includes everything in the other 2 tiers, plus a live 2-day workshop designed to turn theory into practice. Confident Nurse Academy really is the only program that helps you get clinically confident shift by shift, and I'd love for you to be a part of it. Now, you can preview one of the actual lessons inside Confident Nurse Academy. It is called Confident Code Blue Response, and you can check that out at confidentnurseacademy.com/code blue. I'll put a link to that in the episode notes as well. And now let's jump in and go through a mock code blue together.
Well, hello there. I'm Nurse Mo, and this is the Straight A Nursing Podcast, where I teach nursing concepts and share tips to help you thrive in nursing school and at the bedside. Now, I just recently attended my ACLS recertification class, and it got me thinking about running mock codes, which is something that I'm looking at doing in the hospital. And I wondered if I could run a mock code on the podcast. So that is what we're doing today. We're going to be going through what is called a mega code scenario, where we have a patient who does all kinds of crazy things with their cardiac rhythms. So we have to adjust and do all the different treatments according to the ACLS guidelines. So if you're about to take ACLS and you're nervous about it, or you just want to refresh because it does, your knowledge kind of falls off after you take that class because it is a 2-year cycle. Your cert is good for 2 years. I always feel really confident for about 3 weeks after I recert for ACLS, and then things start to fall out of my memory. So I thought it'd be great to have a quick way to review the algorithms so that we can stay on top of this complex topic. So if that sounds like you, or you're just curious to know maybe what happens during a code, what's going on in a code, if you're a student or a new nurse and you're just not sure what all the hustle and bustle is about, this episode is for you as well. Now, before we hop into this mega code scenario, let's take a quick minute for our listener shout out. And this one goes out to Chloe, who says, I'm a 22-year-old nursing student in an accelerated program, so I am in a constant time crunch with little to no time to take breaks from school and work. I often throw on the podcast while I meal prep for the week, drive, take baths, or even work out for a guilt-free break from studying. Nurse Mo explains difficult concepts in a calm tone that allows me to absorb the information without overwhelming me. Thank you for putting in the time to help us. We truly appreciate you. Well, I truly appreciate you too, Chloe, and thank you so much for sharing your experience with the podcast and how it kind of helps you take those guilt-free study breaks while still reviewing important concepts for school. I wish you the very, very best. Okay, are we ready to dive in to our mock mega code? All right, so your patient is Mr. Williams. He is a 63-year-old male with a history of coronary artery disease, hypertension, obesity, type 2 diabetes, COPD, and recurrent cellulitis. His wife brought him to the emergency room because he was complaining of heart palpitations. You start an IV and place Mr. Williams on the monitor. So the time is 14:10, and you see that he is in supraventricular tachycardia, or SVT, at a rate of 160. His blood pressure is 106/72, and as far as symptoms go, at this time, he is asymptomatic. He's just saying, I notice I can feel my heart beating really fast. So I'm going to ask some questions and pause for a little bit to give you time to answer. So it's kind of like a little pod quiz, and then I'll tell you the answer so that you can kind of think through this mega code scenario. So first question is, what defining characteristics of that EKG tracing tell you that Mr. Williams is in SVT? So there's going to be a couple of key things here to tell us that Mr. Williams is in SVT. One is the rate. The rate is above 150. Second, we can see that the QRS complex is narrow. It's not a wide QRS complex. It's narrow or normal. And then the other defining characteristic that's really going to clue us in to the fact that this is SVT is that we don't see any P waves. Okay, so rate above 150, narrow QRS complexes, and absence of P waves. That tells me SVT. So what treatment is warranted for Mr. Williams at this time? Remember, he's not symptomatic. His blood pressure is good. He's not complaining of shortness of breath or chest pain or anything like that. So what are we going to do first? The first thing we're going to do is the least invasive thing. And in the case of SVT, we're going to try a vagal maneuver. And we want to do this because a vagal maneuver is going to enhance the vagus nerve, enhance the parasympathetic nervous system. That was a mouthful. Enhance the parasympathetic nervous system and get that heart rate to slow down. It's going to put on the brakes if it works. And how do we do a vagal maneuver? What are a couple of ways we can do a vagal maneuver? Yeah, so one is we could have him bear down like he's having a bowel movement, or we could have him blow on a syringe. So you keep the plunger in the syringe and you hand him the syringe and you say, try to blow this plunger out of the syringe. And it's going to be really hard. It's going to create a lot of intrathoracic pressure, causing him to bear down by doing so and vagal. But repeated attempts to terminate the SVT in this way are not successful, and it is now 14:15. What is the next treatment you anticipate the MD ordering? So the next treatment for Mr. Williams is going to be a medication, and that medication is adenosine, 6 milligrams via a rapid IV push. And when I say rapid IV push, I mean real quick IV push with a real quick flush after it. And the reason we want to push this medication so quickly is because it has to get to the heart very quickly in order to work. It has a very short duration, very short half-life. If you pushed it slow, by the time it got to the heart, it may not be effective anymore. So you need to push it really fast, and you want to get it into a nice big vessel that can carry that medication to the heart quickly. The AC is a perfect vessel for this. And so you give the adenosine, and what do you anticipate seeing on the monitor right after this intervention is done? You anticipate seeing a brief period of asystole for about 7 seconds. So don't panic when you see this. That means that the medication was administered quickly enough to have the intended effect. Heart's going to kind of take a pause and then hopefully reset the SA node to function properly. So a minute later at 14:16, we've given our adenosine, but it did not convert Mr. Williams out of SVT. Darn it. So at this time, the rhythm is still SVT. The heart rate is still 160. His blood pressure is okay. It's 104/70. And his SpO2 is 96% on room air. Symptoms, as far as they go now, he's not really unstable, but he is showing some heightened anxiety, probably because the adenosine scared him, right? I've heard patients say that it feels like they've got kicked in the chest because of the effect that it has on that cardiac muscle. So the next question is, what is the next treatment that you anticipate the MD ordering for Mr. Williams, assuming, of course, that the MD is following ACLS guidelines? That next treatment is going to be another dose of adenosine, but at a higher dose, and that is 12 milligrams, and that is also given via rapid IV push with a rapid flush. And again, of course, we anticipate seeing that brief period of asystole. Now at 14:17, so a minute later, unfortunately, we've given our adenosine a second time, and it has also not converted Mr. Williams out of SVT. You call the MD to let her know, and she tells you she'll be there to see the patient in a few minutes. So right now, here's our situation. We are in SVT at a rate of 160, blood pressure is 107/74, SpO2 is 97% on room air, and there are no new symptoms. Now at 14:32, you check in on Mr. Williams, and he is now complaining of dizziness, shortness of breath, and some chest discomfort. You take a blood pressure and see he is now hypotensive. So here's our situation now. Rhythm is still SVT. Heart rate is 160. Blood pressure is 87/50. SpO2 is 90% on room air. Symptoms are now dizziness, shortness of breath, and some chest discomfort. So Mr. Williams has definitely gone from kind of a more stable situation to a more unstable situation. And why do we think his blood pressure is dropping? What's going on in the heart with his hemodynamics? So one reason why his blood pressure is dropping is because in that really fast ventricular rate that the heart is going through, what do you think happens to ventricular filling? It's not going to be as adequate. And with reduced filling time, then we have reduced volume in the ventricle, and from there, reduced cardiac output, which leads to lower blood pressure. And then when blood pressure is lower, venous return is lower, preload is lower, and then that just is a cycle of reduced cardiac output. And that is what is contributing to his symptoms here. So, in addition to supplying him some oxygen, because he did feel short of breath, we're going to give him some oxygen. What intervention is now indicated according to ACLS guidelines? So, what are we going to do to help him get out of this SVT? The answer is synchronized cardioversion. Good job. Even if you didn't say it, but you thought it somewhere in your heart, you thought synchronized cardioversion, but maybe you said defibrillation. It's okay. I think you knew it in your heart. We are going to synchronized cardiovert this guy at 50 to 100 joules, and that depends on the specific device that you are using. So what do we mean when we say we are synchronizing this shock? Synchronize the shock, we are telling the defibrillator to look for the R wave because we want that shock delivered at a very specific time in the cardiac cycle, and we'll get to why that is in just a moment. But the difference here when it is synchronized is that the shock is delivered on the R wave, okay? Now, what do you need to do to adjust the defibrillator to ensure that this intervention is done correctly? You have to put the device into synchronized mode or sync mode. It will not default to that. It's going to default to the defibrillation mode. So every time you want to deliver a synchronized shock, you must turn on that sync feature and put it into sync mode. So what happens if you don't do this? Let's say we have Mr. Williams here who is in SVT, and we don't put the defibrillator into sync mode and we shock him with an unsynchronized shock or a defibrillation shock. What could happen? What can happen is very bad. What can happen is that that shock is going to be delivered just whenever you push that button, right? So it may be delivered during the refractory period of the cardiac cycle, and this can cause the patient to go into ventricular fibrillation. This is called R on T phenomenon, and you definitely want to avoid it. So make sure you know how to place your device into sync mode. Now, what other rhythms might you use this same intervention for, this synchronized cardioversion intervention? You could use this for rapid AFib or a flutter and if we're going to use it in AFib or a flutter, we're typically using it in a patient that we know does not have a clot formed in their heart. So it would be most likely the patient who just went into rapid AFib or a flutter. And then we could also use it in VTAC with a pulse. Okay, so now it is 14:35, so about 3 minutes have passed. We've administered the synchronized shock, and Mr. Williams' ECG tracing shows conversion to sinus rhythm, but he still remains symptomatic. So our rhythm is normal sinus. His heart rate is 115. His blood pressure still a little low, 88/63. And we've got him on 4 liters nasal cannula. His symptoms are that he's mildly hypotensive, he's weak, and he's slightly confused. Like he says, "What's going on?" He doesn't know what's going on. Okay, that was my impersonation of Mr. Williams. How was that? Okay, all right, so a couple minutes go by. It's now 14:38. We're monitoring Mr. Williams very carefully, and we witness the conversion to ventricular tachycardia on the monitor. So we look up, our rhythm is ventricular tachycardia at a rate of 110. Blood pressure, it's not reading. You're getting like the question marks that say it's not getting a reading. His SpO2 is rapidly dropping, and you look at Mr. Williams, and the symptoms he is displaying are that he is having agonal breathing and he's unresponsive. So what is the first thing we want to do here? We're going to check for a pulse because that is the first thing, right? Our patient's unresponsive, check for a pulse. Now, how about the next thing we want to do? We've confirmed he has deteriorated to pulseless ventricular tachycardia. What are we going to do next? The very next thing we want to do is start compressions while we're charging the device to defibrillate. Remember, we've already got the device here. We've already used it. The patches are already on him. It's already going to revert back to defib mode. So really, all we need to do is defib this guy, but we can start CPR and do CPR for a few seconds while the device is charging. Now, we're also going to be performing bag valve mask ventilation for Mr. Williams because he has agonal breathing. That's not sustainable. So we're going to have somebody on the airway, and then we're going to have compressors doing the chest compressions. What is the ratio of chest compressions to breaths in this situation? That ratio is 30-2. Very good. Okay, so we deliver a shock at 200 joules. What is next in our algorithm? We are immediately going to resume CPR, and we're not going to stop to check a pulse. We're not going to even stop to look at the monitor. We're just going to hop right back on that chest and get those ventilations going, and we're going to do that without any pauses for 2 minutes. So after 2 minutes of CPR, you pause for a rhythm and pulse check. And what we see is he's still in VFib. We don't have a heart rate and he remains unresponsive. So following ACLS guidelines, what is your next intervention? So to recap, we have charged and defibrillated. We have given 2 minutes of CPR. So next is, that's it. We're delivering a second shock. And then what? Immediately resuming CPR with a new compressor. Very, very important that you switch chest compressors every 2 minutes because it is very, very difficult to do and extremely tiring. So you want to make sure you're getting somebody fresh in there. Okay, it is now 14:42. What intervention is recommended at this point in the algorithm? So we've restarted, we've given that second shock, we've restarted CPR. What can we also do right now? We can give a medication. And what medication is that? That medication is epinephrine 1 milligram IV push, or IO if you happen to have an IO. What else should the MD be considering at this point in the code? They should be thinking about trying to secure an advanced airway. Now, are we going to stop compressions while the MD intubates this patient? Ideally, no. Ideally, chest compressions will continue while that endotracheal tube is being inserted. Now, if the MD needs you to stop compressions, they'll let you know, and that pause should not last longer than 10 seconds. Now, if that airway cannot be inserted in that time, resume ventilating the patient with the BVM. That's what ACLS and the American Heart Association want you to do. Okay, so 2 minutes go by. At this point, Mr. Williams is intubated, hooray, and resuscitation attempts are ongoing. Now, what is our ventilation rate when we have an advanced airway in place? That is 1 breath every 6 seconds. Very good. After 2 minutes of CPR, that's circulating all that epinephrine around, what is your next step? You got it. We're going to pause very briefly for a rhythm check and switch compressors. Now, how long should that take to check a pulse and switch compressors? We do not want to take more than 5 seconds, ideally, if we can do that. Definitely no more than 10, but try to keep it to 5 or under. At this point, you confirm Mr. Williams remains in ventricular fibrillation. What is the next intervention? You got it. We are going to deliver another shock and immediately resume CPR with that new compressor. Now, at this point, it is 14:46. Mr. Williams has received 3 shocks and 1 dose of epinephrine. Your team has switched compressors and started another round of 2-minute CPR. What intervention could be next when following the ACLS guidelines? Next in the ACLS guidelines is an antiarrhythmic such as amiodarone at 300 milligrams IV push or lidocaine at 1 to 1.5 milligrams per kilogram IV push. Guess which one is easier to figure out the dosing on? The amiodarone. So you may see that used more often, but there is starting to be maybe a shift more towards lidocaine. It will be interesting to see what the evidence shows in regards to that. So as CPR is underway for 2 minutes, what can the team be doing during this time? Something really important to start thinking about are reversible causes, and you might hear these called the H's and T's. And if we can identify a reversible cause, we might be able to treat it and fix this whole underlying heart problem. So the H's and T's are hypoxia, hypothermia, hypo and hyperkalemia, hypovolemia, hydrogen ions or acidosis, and so that's the H's. And then the T's are toxins like overdose, tamponade, cardiac tamponade, tension, pneumothorax, and thrombosis, which is referring to a pulmonary embolism or a myocardial infarction. So while we consider the H's and T's, let's take a quick break, and when we come back, we will resume our code with Mr. Williams. So it is now 14:48. From the time Mr. Williams lost his pulse, it has been 10 minutes. So after we have done that last round of 2 minutes of CPR, your team pauses for a rhythm check, and they see that the rhythm remains ventricular fibrillation. Heart rate is, of course, undetectable. Symptoms are that he's unresponsive. What is your next intervention as you follow ACLS guidelines? Remember, the last thing we did was we gave an antiarrhythmic, and then we gave 2 minutes of CPR. Yes, we're going to deliver another shock and immediately resume CPR with a new compressor. So now to recap, Mr. Williams has received 1 dose of epinephrine and 1 dose of amiodarone. What medication may be utilized next? Epinephrine, 1 milligram IV push. Now remember, we give epinephrine every 3 to 5 minutes when we're following the VFib and pulseless VTAC ACLS algorithm. Since we gave amiodarone in that second medication time slot, essentially, then we are able now to give epinephrine again because it's been at least 3 minutes since the last dose. At our next rhythm check at 14:50, we see that Mr. Williams is now, unfortunately, in asystole. So what 2 treatments that we have been a part of our pathway will no longer be used due to this rhythm change? So following the asystole algorithm, we're not going to be utilizing an antiarrhythmic such as amiodarone, and we're not going to be defibrillating the patient. We do not shock asystole. So what is the treatment for asystole? The treatment's going to be continuous CPR and epinephrine every 3 to 5 minutes. Note that some facilities may have a max dose of epinephrine, and this is up to the MD's discretion. Generally, pre-hospital is most likely going to have a max dose of 3 to 4 milligrams or so. But note, if you're working in the inpatient setting with an MD, I mean, they don't even have to follow ACLS. They can order as much medication or whatever medication they want. So just know that the amount of epinephrine given will be up to the MD's discretion. You notice as you are monitoring Mr. Williams and the code, you notice that the end tidal CO2 reading is 12 millimeters of mercury. What do you do with this information? You will coach the compressor on ways to improve their chest compressions. They want to maintain that adequate depth. They want to maintain that adequate rate while allowing for full chest recoil. So what is the adequate depth of compression in an adult patient? That's going to be 2 inches or 5 centimeters. And then what is the rate that we want to use? 100 to 120 compressions per minute. After coaching, you see that the end tidal CO2 reading rises to 16 millimeters of mercury. What do you do with this information? This is when you provide positive feedback to the compressor, since this value indicates that chest compressions are adequate. We want that end tidal CO2 to be at least 15 millimeters of mercury. So it is now 14:53. You're preparing another dose of epinephrine to have ready when the end tidal CO2 reading quickly rises to 65 millimeters of mercury. What does this indicate, and what should you do? So this indicates ROSC, or return of spontaneous circulation. And you should check for a pulse and respirations, though pretty sure if their end tidal rises up that fast, they're gonna have a pulse. So you observe spontaneous chest rise and fall as you check for a femoral pulse. And yes, patients can still breathe even when they have endotracheal tubes in place. They can still breathe on their own. So that is what Mr. Williams is doing. He's initiating his own breaths. And when you check femoral pulse, voila, you have a femoral pulse. And when you look at the monitor, what you see is you see P waves, you see QRS complexes, you see that the P wave to P wave intervals are consistent, and you see that the R to R intervals are consistent, but they really don't seem to have any correlation to each other. It's not like each P wave is causing a QRS complex that follows. It looks like the P waves are doing their own thing and the QRS complexes are doing their own thing. So what rhythm is this? This is a 3rd degree heart block. So here's our scenario. The rhythm is a heart block with bradycardia, 3rd degree heart block, which is very bad. Heart rate is 41 beats per minute. Blood pressure is 74/44. SpO2 is 99% on 100% FiO2. Remember, he's on the ventilator. He's getting oxygen through the ventilator, though he is able to initiate breaths on his own, which is good news, but he is unresponsive. Note that once CPR is no longer being done, we can now put the patient on a ventilator. And we can put him on a ventilator mode where he's maybe initiating some of the breaths. Maybe we're assisting with that. That'll be up to the respiratory therapist or the physician. So in this case, while we are doing chest compressions, the patient is going to have that ET tube in place, but we're going to be putting the bag valve mask. It would not be the mask, it would just be the bag. We're going to attach the bag to the endotracheal tube and give breaths manually. But once we have pulses back, we're no longer doing chest compressions, we can hook him up to a ventilator. So that is what would happen at this stage. Is Mr. Williams stable or unstable at this point? I hope like heck you said unstable, so good job, very good job. So in bradycardias, you may remember that we use atropine a lot, 1 milligram atropine to treat bradycardia. What are a couple of reasons why we're not going to give atropine in this case? Well, one is atropine does not work on high degree heart blocks, so you could give it, but it's not going to do anything. Secondly, Mr. Williams is very unstable at this point. We're not going to wait around for medication to work. We're going to jump right to the most intense and effective treatment, which is coming up next. So what do you think that treatment is for Mr. Williams? It's pacing. We're going to pace his heart and make it beat at a rate of 60 to 100 beats per minute, okay? So it is now 14:54. You switch the defibrillator to pacing mode. Again, you're not going to leave it in defib mode. You're going to turn the little dial to pacing mode and set it to a rate of 80 beats per minute and initiate pacing. You look at the monitor and observe pacing spikes at regular intervals, just like you expect to see them. However, you notice that a lot of those pacing spikes do not have a QRS after them. So what does this mean, and what do you need to do? The absence of a QRS after every pacing spike indicates a failure to capture. So, the intervention for this is to turn up the milliamps on the device until the patient has both electrical and mechanical capture. So, how do you confirm mechanical capture? All you got to do is correlate the QRS with a pulse. So feel for a pulse and see that it corresponds to each QRS on the monitor. When that occurs, you have mechanical capture. So it is now 14:55. At this point, you have a stable paced rhythm with reliable capture. Good job. You see a little movement out of the corner of your eye and see Mr. Williams is trying to open his eyes and he's moving his hands a little bit. You ask him to show you 2 fingers and he follows this command. This is fantastic news. So here's our situation. Our rhythm is that we are having a paced rhythm. Our heart rate is 80. Blood pressure is 115/64. Hey-yo, really good there. And SpO2 is 99% on 100% FiO2 on that mechanical ventilator. As far as symptoms go, he will follow simple commands, but he's very lethargic and barely opening his eyes. What can be done next to further support adequate oxygenation in Mr. Williams? So one of the things we can do is ensure we're not giving too much oxygen. There have been lots of studies about the over-oxygenation of patients following cardiac arrest, following codes. And right now, the ACLS guidelines after return of spontaneous circulation are to titrate oxygen to an SpO2 of 92 to 95%. Now, of course, this is going to be up to the MD, but you are likely to see oxygen titrated to 92 to 95% rather than keeping it really, really high. What treatment do you anticipate next for Mr. Williams if that high degree heart block persists? So Mr. Williams may get a transvenous pacer, and then if it really is persisting, a permanent pacemaker. We're not going to keep these pacing pads on for a really, really long time. Really uncomfortable. Not anyone's best day ever. So he may get transvenous pacing, or maybe he'll go down to the surgery and get a permanent pacemaker placed. Now that Mr. Williams has regained consciousness, even though he's quite lethargic, he will wake up, he will follow commands, and has a normal blood pressure. What can we do to help his comfort? I mentioned that transcutaneous pacing is really uncomfortable. So, can we do anything to help him with that? We can consider sedation. So, according to ACLS guidelines, midazolam or Versed is the medication of choice. It does depend on him having a good blood pressure. So, you may not see every patient get sedation. This is definitely something to bring up if you notice that your patient could be a good candidate for sedation while being transcutaneously paced. Now, it's time to transfer Mr. Williams out of the emergency department. Where is he going to go? So Mr. Williams is either going to go to the cardiac ICU for additional monitoring and diagnostics, and they could potentially put in a transvenous pacer at the bedside in a unit like that. He may go to the cardiovascular surgery suite and get a pacemaker placed. It really just depends on what the intervention is going to be. But the main thing is he's going to leave the ER. He's not going to go to a tele floor. He's not going to go to a med surg floor. He's going to an ICU and preferably a cardiac ICU. So, way to go. Good job. You successfully resuscitated Mr. Williams using ACLS guidelines. You went through a let's see, what algorithms did we go through? We went through the tachycardia algorithm with his SVT, and then we went through the VFib algorithm, and we went through the pulseless VTAC algorithm, and then we went through a bradycardia algorithm. So you did all kinds of stuff today in this review with our good friend and patient, Mr. Williams. So if you want to learn more about your first code blue and surviving that scary experience, then I've got an episode for you. That is episode 153. So I will put a link to that in the episode notes so you can hop on over to that. And then if you also want to dive deeper into pacemakers, then go and listen to episode 335. So I hope you found this helpful and a great review of ACLS so that you feel confident and prepared and know what to expect if you do find yourself in a code situation. So if you're not yet following the show, I invite you to do that so you never miss an episode. And I will see you back here again soon. Bye for now.
This podcast is brought to you by Straight A Nursing, a proud member of the Airwave Media Network. For more educational podcasts, check out airwavemedia.com. And for more nursing-related content, go to straightanursingstudent.com.
Some things never go out of style, like trust, reliability, and driving a Toyota. Take the legendary Camry and Corolla, designed for comfort, engineered for performance. Hurry in. Offers end November 3rd. Toyota, let's go places.